Welcome to the ICU Management and Practice DigiConf Clinical Haematology. Our Editor-in-Chief, Professor Jean-Louis Vincent, will moderate the session. Our panelists include Marc Samama, Professor of Anaesthesiology, Flavio Nacul, Critical Care Physician, Laveena Munshi, Critical Care Physician, and Victoria Metaxa, ICU Consultant and Clinical Lead for Critical Care Outreach Services. Our moderator, Professor Jean-Louis Vincent, will join us shortly. In the meantime, let us welcome our first speaker, Marc Samama.
Good afternoon. I'm going to focus now on the reversal of direct oral anticoagulants. Have no conflicts of interest, no disclosure, but I'm part of the American College of Chest Physicians 10th ongoing guidelines on the perioperative management of antithrombotics. I'm also the chair of the guidelines of venous prophylaxis, venous thromboembolism prophylaxis for ISAIC. I'm an expert for the European Medicine Agency, and as I'm the chair of NATA, the Network for the Advancement of Patient Blood Management, Hemostasis, and Thrombosis, I may have some connection with some companies, of course. There are three ways to get rid of DOACs: to act on absorption, to act on the mechanism of action, and to act on elimination. Let me focus first on charcoal. Charcoal is acting on absorption. In these 18 healthy volunteers treated with apixaban 20 milligram, which is a quite high dose, 50 grams of activated charcoal were given either 2 hours or 6 hours after the apixaban dose. And charcoal was able to decrease the mean elimination half-life of apixaban from 13.4 hours down to 5 hours. And charcoal may be very effective pending you give it in 6 hours interval. The second way to act, maybe the most popular and the most effective for the moment, is a kind of indirect antidote. It's a PCC, prothrombin complex concentrates. In this systematic review of small case series, Pyran and co-workers have added 340 patients who received PCC for direct factor Xa inhibitors related major bleeding. And these patients were treated with PCC with a dose around 25 units per kilo. And the pooled proportion of patients with effective management of major bleeding reached 69% using the ICH criteria, and even 77% in 8 studies that did not use the ICH criteria. The death toll was quite high, 16%, and the thromboembolism rate was low, 4%. Please keep this 4% in mind. But unfortunately, we have a very low certainty in these single-arm case series, so it was difficult to determine whether atrial 4-factor PCC, in addition to cessation of the treatment, was more effective than the cessation alone, of course. 2 specific antidotes are available. First one is hydrosuzimab, which is a fully humanized monoclonal antibody fragment, which is acting directly on the bigatron. Its affinity is 350 times stronger than its affinity for thrombin. It's very, very effective. And in this study, the reverse AD study, you may see that after a bolus, an IV bolus of hydrosuzimab, the diluted thrombin time in patients with uncontrolled bleeding or in patients supposed to undergo emergency surgery was controlled for 24 hours. So this drug was acting for 1 day with a full control on the plasma concentration of dabigatran, no more plasma concentration of dabigatran, and even the activated partial thromboplastin time was controlled. The efficacy was quite good in the group of bleeding patients. The median time to the cessation of bleeding was 2.5 hours, and in group B, for patients scheduled for procedures, periprocedural hemostasis was assessed as normal in 93% of the patient within 1.6 hours. The thrombotic toll reached 6% in the first group and 7% in the second one, and the mortality rate was quite high, just below 19%. The second one is andexanet alpha for anti-10A agent. It's a recombinant factor 10A with no glutamine and a catalytic activity. It inhibits direct and indirect anti-10A agents. It acts almost immediately in 2 or 5 minutes, but half-life is very short. As you may see on this figure, if you give a bolus after 1 hour, the level of plasma anti-10A in apixaban-treated patient or rivaroxaban-treated patient is back to control as compared to control in black here and red, the andexanet-treated patient. Only if patient receive a continuous infusion, a 2 hours continuous infusion after a bolus, you will control the anti-10A level in both groups for 2 hours, but then you go back to the control. In the full study report of Annexa 4, the only large study, including at the beginning 352 patients, but only 254 were assessed. They were treated with either apixaban or rivaroxaban, and they received 400 or 800 milligrams of andexanet followed by a 2-hour infusion. And the bleeding was predominantly gastrointestinal or intracranial. And have a look to the definition of intracerebral hemorrhage. An increase, not a decrease, an increase in volume of 20% or less from baseline at both 1 hour and 12 hours after infusion was considered to be excellent hemostasis, not a decrease, an increase. Whereas an increase in the volume of 35% or less was considered to be good. Well, even with this very positive definition of bleeding, the results were not that great. Only 82% were considered as excellent or good, and there was a very high thrombotic event toll, and the death toll reached 14%. This drug was approved by FDA, but with a boxed warning for thromboembolic risk, ischemic risk, cardiac arrest, and sudden death. Stating that the treatment with the agent has been associated with serious and life-threatening adverse events, including arterial and venous thromboembolism event, cardiac arrest, sudden death, and ischemic events such as myocardial infarction and ischemic strokes. And when comparing 4-factor PCC, hydrosuzumab and andexanet, if the death toll is quite comparable in this meta-analysis, the effective hemostasis was also quite comparable, but the thromboembolism rate was almost doubled in the andexanet alpha group. So my take-home messages for the reversal of DOACs is that there is a trade-off between the bleeding risk and the thrombotic risk. For an emergency procedure, shark oral within 6 hours could be effective. I don't have the time to develop on dialysis, which is only dedicated and possible for dabigatran. And we also have PCC and hydrosuzumab, but we have some question on the use of the antidotes. A reversal of DOACs has been underestimated by industry. We have some reassuring data on PCC, very few data on activated PCC. The use of hydrosuzumab has to be restricted to severe bleeding, and we don't have any serious idea of the side effects. And I would recommend PCC for anti-10 agent for the moment while waiting for specific antidote. I'm not sure that andexanet alpha and serapirantag, no time to talk about that, are the best one for the moment. Thank you for your attention. Now, I think it's time to move to the second speaker, Dr. Flavio Nacul from Rio de Janeiro. Flavio is a critical care physician in the University Hospital, Federal University of Rio. and is going to talk about anemia in the critically ill. What is the major culprit? Please.
Hello, everyone. My name is Flavio Nacul. I work at the Federal University of Rio de Janeiro and Pro Cardíaco Hospital, both in Rio de Janeiro, Brazil. It's a pleasure to take place in this webinar where I'm going to talk about anemia in the critically ill. What is the major culprit? Next slide, please. Thank you. My talk will be based on this review I wrote with two colleagues in England, Valentina de la Torre and Kaushin Baumik. Next. Next slide, please. In this presentation, I will cover definition, prevalence, etiology, and finding a major culprit. Next slide, please. According to the World Health Organization, anemia is defined as hemoglobin concentration below 12 grams per deciliter in women and below 12 grams per deciliter in men. Next slide, please. About 2/3 of patients are anemic at admission in ICU. Next. Nearly 100% of the remainder will become anemic during their ICU stay. Next. Furthermore, 77% of patients are still anemic at hospital discharge. Next. Surprisingly, the prevalence of anemia post-hospitalization is 56% at 3 months. Next. And 52% at 6 months. Next. There is a large body of evidence suggesting that low hemoglobin levels are correlated with high SOFA score, increased hospital length of stay, and elevated mortality. Next. Regarding the etiology, I have selected the most relevant causes in no particular order. Next. Including hemodilution, blood loss, low erythropoietin, new cytolysis, and other causes. Next. Number 1, hemodilution. In half of the cases, anemia could be explained as a result of increased plasma volume rather than by a reduction in red cell mass, producing unnecessary transfusions. Number 2, blood loss, either through bleeding or phlebotomy. Next. Excessive blood draws are a cause of iatrogenic anemia. Doctors should not be vampires. Strategies to reduce anemia due to blood sampling procedures should be implemented. Number 3, hepcidin is the main regulator of plasma iron concentration. After an inflammatory stimulus, cytokines released by activated leukocytes induce hepcidin synthesis. On your left, iron obtained from diet passes through the intestinal enterocyte and can move into the plasma by ferroportin. On your right, old erythrocyte, previous, can be phagocyte, still the previous one, can be phagocyte by macrophage and recycled towards the blood by ferroportin 2. Hepcidin blocks ferroportin. Next. In other words, in inflammation, liver produces hepcidin that blocks the release of iron from macrophage and from the intestine. Next. So high hepcidin decreases iron delivery for erythropoiesis, causing a functional iron deficiency anemia. Next. Number 4, low erythropoietin. Studies show a blunted response of erythropoietin to anemia, secondary to increased levels of cytokines. Next. Number 5, new cytolysis is a selective destruction of new erythrocytes, can explain how red blood cell can be reduced over a short period of time. Next. Neocytolysis was first described in astronauts to explain space flight anemia. Next. In microgravity, blood is pulled centrally, causing plethora. This plethora reduces erythropoietin, and this causes new cytolysis. New cytolysis decreases red blood cells, causing anemia in 3 to 5 days. Next. Number 6, other cause includes drugs and nutrition deficiency. Next, please. In conclusion, the cause of anemia in critical illness is complex and multifactorial. As humans, we like to place the blame on others. Why do we blame others for our failures? Next. In case of anemia in the critical ill, we can blame, in most of the cases, high hepcidin and low levels of erythropoietin. Next. Thank you very much for your attention. I'll be more than happy to take some questions.
Thank you very much, Dr. Flavio Nacul. Now, the next speaker is Dr. Laveena Munshi, who is a critical care physician in the Interdepartmental Division of Critical Medicine, Mount Sinai Hospital, Sinai Health System, University of Toronto, Canada. The topic is critical care across patients with hematologic malignancies. Please, Laveena.
Thank you. Thank you for the opportunity to present this afternoon. As mentioned, I'm a critical care physician at the University of Toronto, and I have an interest in oncologic critical care, and in particular, critical care of patients with hematologic malignancies. With regard to disclosures, the only relevant disclosure is that some of the data that I'll be presenting is data that was supported by the Leukemia and Lymphoma Society of Canada from a grant that I obtained through with one of my colleagues, Dr. Geetha Mehta. I just wanted to confirm that my slides are sharing. Can everyone see my slides? Yes, perfect. Okay. Now, many of you may recall a time period when there was a lot of historic pessimism surrounding candidacy for ICU admission across patients with hematologic malignancies. But due to advancements in critical care management, oncology care, and infectious disease practices, we've seen a significant improvement in critical care mortality over the years across all subtypes of cancer, as well as some subtypes of hematologic malignancy. Now, this is not just limited to the fact that we've potentially decreased the threshold for ICU admission for certain patients with cancer. This mortality decrease has been seen irrespective of intensity of organ support, which was demonstrated very beautifully in this very large Brazilian observational study that was published last year that demonstrated decrease in mortality over the past few decades, irrespective of organ support received. So this historic pessimism surrounding candidacy is outdated. I will acknowledge that heme malignancy mortality is higher than the general population and solid tumor population. However, now I feel like we can start to focus our attention more on contemporary data surrounding incidence of critical illness, the critical care conditions that present themselves, who should be coming to the ICU, and even long-term outcomes. And over the next few minutes, I'm going to provide a brief overview of some contemporary data on these topics. So to evaluate the incidence of critical illness, myself and my colleague, Dr. Bruno Ferrero, we conducted a population-based cohort study with colleagues in Toronto. And looking at population-based data in the province of Ontario, approximately 14% of patients with hematologic malignancy were admitted to the ICU within 1 year of diagnoses. And not surprisingly, incidence varied based upon malignancy subtype, with some, like acute myeloid leukemic patients, having a higher likelihood of requiring ICU admission within 1 year following diagnosis. Now, when I reflect upon critical care conditions across patients with hematologic malignancies coming to the ICU, I like to divide them into disease-associated critical illness and treatment-associated critical illness. And obviously, I'm not going to review this in depth, but I do want to highlight that respiratory failure and sepsis continue to be the most common causes of ICU admission. Increasingly in the future, we may see more treatment-associated toxicities, such as those from CAR T-cell therapy, as indications for CAR T-cell therapy expand. And Dr. Metaxa in the next slide, in the next presentation, will expand on this in greater detail. Now, importantly, there are some very specific causes of critical illness that are associated with hematologic conditions. And this is outlined in our paper that was led by Dr. Jenna Spring. And in this paper, we highlight AML emergencies, neutropenic sepsis, SVC syndrome, hyperviscosity syndrome, as well as complications following stem cell transplant. But there are two things I wanted to highlight are important in considering your history of patients with hematologic malignancies that develop critical illness. And the first is that it's important to understand the phase of treatment that they're in. On their journey from diagnosis to outcome, whether it be cure, sustained cancer control, or end of life, there are many time points at which these patients may develop critical illness and may warrant admission to an ICU. It could be at presentation, during induction, or peak of treatment-associated immunosuppression, and these are associated with distinctly different causes of critical illness. Now, the second is that it's important to really understand the mechanism of immunosuppression of this patient population, whether it's driven by the disease or the treatment, because this changes your differential as to what the infectious agent may be if the cause of critical illness is driven by infection. And a nice summary of this is highlighted in one of Dr. Ali Azalei's papers that was published in Lancet Respiratory Medicine from 2018. So now that we have this shift in our perspective surrounding candidacy, I will acknowledge once again that there are a subset of patients with hematologic malignancy who continue to do poorly in the setting of critical illness. So who should we be offering ICU to in this population? When we look at contemporary data surrounding sepsis and septic shock outcomes, a recent cohort study by Dr. Lemieli from Paris evaluated approximately 2,000 patients with cancer and sepsis and looked at changes in mortality over time. The graph on the left shows outcomes across patients with solid tumor with sepsis, and the graph on the right, outcomes of patients with hematologic malignancy and sepsis. And when we look at their 30-day mortality, their in-hospital mortality is approximately 30%. Now, acute respiratory failure prognosis has also markedly improved, but still remains high and higher than the non-cancer cohort, as was nicely demonstrated in a secondary analysis of the LungSafe database, looking at a lower likelihood of survival in immunocompromised patients compared to non-immunocompromised patients. And this is obviously also true across ARDS for patients with malignancies. Mortality remains 50 to 60% consistently across observational studies in this patient population. When we look to observational studies of consistent factors associated with mortality, comorbid conditions, poor functional and frailty status, treatment refractory graft versus host disease in allogeneic stem cell transplant patients, the need for invasive mechanical ventilation, but in particular, invasive fungal infections, a number of organs failed continue to be associated with mortality across many studies. And interestingly, subtype of malignancy is not associated with in-hospital and ICU mortality when you adjust for severity of illness factors. So when I reflect upon who should be coming to the ICU for each heme malignancy consult that I have, and I reflect upon the potential utility of ICU admission, I tend to ask myself, well, what is the critical care condition and associated prognosis? What is the patient-centered objective of this ICU admission? But also, what is the long-term oncologic prognosis without critical illness? What are their treatment options? Have they received them? Will critical illness impact this, and how will critical illness impact this? And a lot of these questions I can't actually answer without the involvement of an oncologist. But I will add, there's some questions where we really do have limited data. So finally, given the improving ICU mortality rates, what happens after the ICU? And unfortunately, there is a paucity of data in this space. Myself and my colleague, Dr. Geetha Mehta, here in Toronto, we just completed our critical care outcomes observational study of hem-onc patients in Canada across 8 ICUs, the results of which we're presenting at our Canadian conference next week, but I thought I would just give you a snapshot of this. Across 400 patients admitted to 8 Canadian ICUs, most had high-risk heme malignancies such as acute leukemia. We had a very high proportion of stem cell transplant patients. Most were admitted with respiratory failure, about half required invasive mechanical ventilation. The ICU survival of this cohort, which was a higher risk cohort, was about 53%, and only 37% of those survivors survived to 12 months, which was 20% of the original cohort. And the lower survival compared to other cohort studies is likely driven once again by the high frequency of high-risk hematologic malignancies. But we also looked at treatment post-ICU at 7 days, 6 months, and 12 months, and we classified patients as having treatment continued as the same treatment plan pre-ICU, whether there was a change in treatment such as a dose reduction, medication change, or no longer a candidate, or no treatments were indicated at that time. And as you can see here at those time points, a large subset had a modification to their treatment regimen. So when we reflect upon the hypotheses for these long-term outcomes in our high-risk hem-onc cohort post-ICU, it could be possibly due to critical illness manipulating or modulating the effectiveness of the anti-cancer treatment that was received pre-ICU, decreasing the likelihood of remission. Critical illness potentially affecting people's candidacy for ongoing treatment, whether it's due to accumulated frailty or organ failure, or maybe those that are predisposed to develop critical illness or those that are predisposed to have a poor long-term outcome anyway. So we have multiple more analyses that are underway to try to better understand those questions. So in conclusion, the incidence of critical illness is not uncommon in the hem-onc population with a higher likelihood across certain higher risk subsets. ICU mortality has improved significantly over the years, so now we need to more meticulously think about longer-term outcomes. Critical illness may develop as a consequence of definitive treatment for hematologic malignancy, which may be administered with curative intent. There are lots of unusual disease processes that can complicate treatment. The etiology is not always easily identified. And when we reflect upon the goals of the ICU admission, it may be more than just trying to bridge an individual to survival with an acceptable quality of life. There's the added complexity to bridging them to ongoing treatment. There are many areas of uncertainty that remain, such as how critical care conditions may be different pathophysiologically in hem-onc versus non-hem-onc patients, whether evidence-based ICU management principles are generalizable to this population, and we certainly need a more granular understanding of drivers of poor long-term outcomes across this cohort. So thank you for your time, and I look forward to the discussion at the end.
Thank you very much, Dr. Munshi. The last speaker is Dr. Victoria Metaxa, who is working as an ICU consultant in the Critical Care Outreach Services, Department of Critical Care in King's College, London. The topic is CAR T-cell therapy, what an intensivist should know. Please.
Thank you very much. Can you see my screen?
Yes, we can.
Fantastic. Thank you very, very much for this opportunity. As said, I'm Victoria Metaxa, and I'm one of the consultants at King's College Hospital in London, UK. And I do have an interest in hemato-oncology patients, and especially those receiving CAR Ts. So I'm going to talk to you a little bit about CAR T therapy. And very speedily tell you what I think we should all know as intensivists when we're asked to look after these patients. These are my conflict of interest. So CAR T therapy is a type of adoptive cell therapy, which basically means that we take cells from a patient and then we manipulate them ex vivo and then we return them back to the patient. It's a type of immunotherapy. The whole point is to enhance the immune response of the patient against tumor cells. And immunotherapy and immunomodulation has gained a lot of recognition when targeting solid tumors and especially metastasis, but now it started spreading in hematological tumors. So what are CAR T cells? Well, they are genetically engineered cells, you can see in the slide that there are a few generations of them. Why do we need to know that? Well, because depending on the type of CAR T that we use, their function and of course their toxicity differs. So the first generation, you see, they only had an ectodomain and an endodomain, so an extracellular portion and intracellular portion. They were very basic. They did the job, but they didn't persist long. So they had higher apoptosis, but they didn't have a lot of toxicity. What we do currently have is the second generation. And you can see in the second generation, we have an extracellular portion, which is where the receptor, which includes the antigen recognition domain, lies. So it's where the domain that will recognize the tumor cell is. Then you have a transmembrane domain, and that primarily supports stability, and an intracellular domain where the activation and the facilitation of the transduction happens. Again, this is very important because by adding this co-stimulatory domain, the transmembrane domain, increased the durability of CAR T cells. But unfortunately, as we'll see later on, it also increased their toxicity. So here you see the whole process, the whole time frame. The time from collection to infusion currently takes 3 to 4 weeks. And I will tell you why this as well is very, very important. So the first step is to take peripheral blood mononuclear cells from the patient with large volume apheresis and then send them to a manufacturer, to the manufacturer facility. Not every country has manufacturer facilities. And for example, still in the UK, we do send our cells to other countries. And that, of course, increases the time frame and the timeline for this procedure. So then you incubate the T cells with a viral vector. You insert mRNA, then you reverse transcribe that to DNA, and then you do have your T cell. Those two T cells, of course, need to be expanded, and they continue to expand and multiply for several days until, and after that, then the product, the finished product, gets shipped back to the hospital and gets transfused to the patient. This is very, very important. And it takes, as we said, up to a month, sometimes even more. It's very important because the patients that will receive T cells are patients that are really sick. They have already received at least 2 lines of other therapy, and without the CAR T cells, their life expectancy at maximum is about 6 months. So they are patients that without this therapy are end-of-life patients, and somehow they need to hold on from the decision to give them the T cells to the actual infusion. And that sometimes can be tricky. So how do these CARs function? So basically, when they see a malignant cell, they recognize it, and they activate, they attach themselves to it, and then they activate. They not only activate, but they start to expand and proliferate. As this happens, then secretion of cytokines, and specifically TNA factor and interleukin-1 and 2 and 6 is what is secreted. So this is how they work, but also this is how their toxicity ensures. So other cells are activated as well, and you see in that slide the macrophages, and then more cytokines, and then you get And then you get all the symptoms that you sometimes get from CAR T cells. And this is how, and this is why, the most common of the toxicities after CAR T cell therapy, which is the cytokine release syndrome, CRS, that's how that is the explanation, the pathophysiology behind it. So the cytokine release syndrome is quite frequent. Sometimes from 60 to up to 90% of all patients that receive the cells will get any kind of any grade of CRS, and up to 20% of them, about a fifth of them, will develop grade 3 or higher CRS. Here you see the categories of CRS. This is a consensus from the American Society of Blood and Marrow Transplantation that came to replace all the various other gradings that we had, and it's very useful now because we all have a common language. So you see that there are 4 grades depending on how sick the patient is, depending on the hypertension, the degree of hypertension, and or hypoxia. Fever is a standard, a gold standard. So to have CRS, of course, you need to have fever. So as intensivists, what we care about, though, is the fact that this grading, yes, has unified things, but it hasn't 100% resolved them. And this is what I mean. Look at the grading 2 and 3 of hypoxia. And for a patient to have grade 2 CRS, they need to have low flow nasal cannula oxygen. And by low flow, they mean oxygen delivered less than 6 liters per minute, and high flow more than 6 liters per minute. I hope you agree with me that this is quite arbitrary. So sometimes some institutions, we never use nasal cannula for more than 3 liters, for example. And what we do use a lot is high flow nasal cannula oxygen, which doesn't really feature in this grading. What is also more important is the grade 3. So for a patient to have grade 3 means they are hypotensive, fluid haven't worked, and they need now a vasopressor, normally noradrenaline. So, excuse me. With and or without vasopressin, the grading system says. So again, this is quite tricky. In the UK, I'm not sure about other countries, but in the UK, for someone to need vasopressin, this is definitely a second line. It means that they are quite sick. So to just have that very vague, and as vague as that, with or without vasopressin, really doesn't answer the question of how sick the patient is. Why is that important? Well, depending on the grading of CRS comes the therapy. So initially, we all give supporting treatments, antipyrexials, paracetamol for the patient. But as they progress to grade 2, then treatment with tocilizumab, which is an IL-6 receptor antagonist, is recommended. And then as they progress to grade 3, and that is why it's very important to know if they're grade 3 or grade 4, apart from the IL-6 inhibitors, then you start to give them steroids and other immunosuppressants like greater doses of methylprednisolone, anakinra, or cetuximab. The second toxicity following CAR T cells, and the reason that they will come to ICU, is this neurotoxicity, or else immune effector cell-associated neurotoxicity. So the pathophysiology behind that is not as clear-cut as CRS. Systemic inflammation seems to be important, but less so than in CRS. IL-6 seems to be more important than IL-1 seems to be more important than IL-6. We have seen pro-inflammatory cytokines in the CSF, in the cerebral fluid, but whether they just cross a blood-brain barrier that somehow it's damaged, or whether the actual CAR T cells engage with cerebral endothelial cells, hence causing neurotoxicity, is not very clear. ICANS, so this neurotoxicity, occurs a few days following CRS. Sometimes it can follow concurrently. Again, there are stages, and as you can see, the most important thing is how to diagnose it, and we use the I-score. The I-score, you can see on the right of this slide, uses 5 different domains, and depending on the scores you get, then you get the grading. The management of ICANS, again, depends on the grade. The low grade is increased neuromonitoring and antiepileptics. Here, we don't give IL-6 inhibitors, we don't give tocilizumab, it doesn't cross the blood-brain barrier, but we do start immediately with steroids. 10 milligrams up to QDS is what we use, with, again, higher doses of steroids and other immunomodulation and immunosuppression to follow. So, again, these patients will come to us, and I think you heard from previous speakers that CAR T therapies are the future. So you will see them more and more in your ICUs. They will come because they have CRS or neurotoxicity, because they have seizures, because they're hypotensive. But the difficulty that we will encounter as intensivists is getting a differential diagnosis. So when they will come, they will be hypotensive, they will require some vasopressors, but they're also severely immunocompromised. So the differential diagnosis is very important. Always consider sepsis, especially, as we said, because they're immunocompromised, because the two conditions can occur together, and because what we have found is up to 40% of these patients will have sepsis within the first month. As patients that have higher grades of CRS, or the sicker they are, more the chances of them having concurrent sepsis is higher. So make sure that you keep close monitoring. Empirical antibiotics are paramount, with quick escalation depending on the clinical picture of the patient, and vigorous diagnostics is of the essence. Other considerations. So we did discuss that there is a long turnaround time between the decision to give CAR T cells and the actual infusion of CAR T cells. That means that some patients might progress waiting for the cells. So again, managing expectations is very, very important, because some of them might be quite sick and not able to actually receive the cells. A second problem is that after infusion of the cells, the response is possible. It is obvious several weeks after the infusion. However, the toxicities will occur days or sometimes hours after the therapy. So the decision to initiate or continue treatment becomes difficult, and becomes difficult. We do know, and we are aware, especially those of us that do hemato-oncology and critical care, what is an ICU trial. So an ICU trial is where you actually admit the patient, you give them full treatment, but time limited. You set some time limits. This in CAR T patients doesn't really work, because, as we said, for us to find out whether the therapy has actually worked needs weeks and not just days. So patient and family expectation management is paramount. Open communication between the hematology team that has invested a lot on these patients, along with our teams, and the family and the patient themselves is also very important, as is close collaboration between teams. So to conclude, CAR T therapy is here to stay. More and more options and more diseases come forward every day. Common toxicities are the CRS and the neurotoxicity, and you will see them in your ITU. Treatment for CRS is the IL-6 receptor antagonist, tocilizumab, whereas neurotoxicity, you start with steroids. Higher toxicities should be managed in ICU, and please have a lower threshold of admitting these patients in your ICU, and close collaboration to also both to treat these patients, but also to set treatment limits is paramount. Thank you very much for that. I'm happy to take some questions.
Our chair, Professor Jean-Louis Vincent, is back. Jean-Louis, it's up to you to chair now.
Thank you very much, and thank you very much, Charles Marc, for having started the introductions. I'm sorry, I was in the train, which was a bit delayed, and then someone pulled the alarm system down, so the train had to stop for a while. But you know, I could enjoy the second half of the presentations. So now we have about 10 minutes of questions, and again, I'd like to thank the four speakers for excellent talks. And if there are questions, I can take them at any time from the audience, from the other speakers. Do not hesitate. Laveena, please go ahead.
Thank you. First of all, thank you for this invitation, and thank you to all the other speakers for those very informative presentations. My first question just surrounds blood conservation strategies. I guess this would be potentially for Flavio or anyone else on the panel. Has there been much data, that demonstrates the efficacy of blood conservation strategies in the ICU and in association with improved outcome? And then in addition to that question, is it your practice to consider using IV iron in your critically ill patients? And I guess maybe in particular, if they're not affected with infection or sepsis?
Flavio, you are on mute.
Hello. Thank you very much for your question. We usually don't use iron in our patient except when they have iron deficiency. Answer your question.
Well, I suppose you're also concerned about the risks of infection when you give iron, and maybe Charles Marc could comment on that.
No, I don't have any personal opinion on, because we don't have many data on the use of iron in the ICU, I believe. So I'm not sure that in our ICU they use iron either.
Okay, Victoria, you don't give iron to your cancer patients, all right? Laveena, you had another question, you said, or is it, do you want to pursue on the iron administration? I would be very cautious. You know, there are quite many data showing that iron administration could favor the development of microorganisms because they love iron to develop, right?
For sure.
Yeah, there's been, I guess, an increasing enthusiasm, I guess, at least in North America, I guess, highlighting the safety profile, but I think there's also been more recent data that's kind of cautioned against its use in the ICU. So more recently, we've been chatting about it across our group, but consistent, I guess, with the other speakers on the panel, we haven't actually routinely adopted it, in particular with patients with deficiency.
I have a question to Laveena. Laveena, what is your approach to non-invasive oxygen strategies in the hematologic malignancy population?
So this is a highly debated topic for my colleagues at my institution. And once again, I can tell you my thoughts and would love to hear everyone else's thoughts on this topic. And currently my approach to different non-invasive oxygen strategies, so high flow or non-invasive ventilation, is actually not very different in my hem-onc patients compared to my non-hem-onc patients. I know there have been historic landmark studies that demonstrated in immunocompromised patients the benefit of using a non-invasive oxygen strategy, such as non-invasive ventilation, to prevent intubation. But now with contemporary practices, those results may not be generalizable to this day and age's ICU population, with advancements in identifying etiology of respiratory failure and advancements in critical care management. And my view currently is that I think there's probably no one non-invasive oxygen strategy that's a one-size-fits-all approach for all patients, hem-onc or not. There's probably different phenotypes, and different types of patients respond better to high flow or non-invasive, or even upfront invasive mechanical ventilation. So currently now, things that make me more likely to forego non-invasive oxygen and jump to intubation includes things like impaired PF ratio less than 150, or higher severity of illness coming in, or if I'm concerned about alveolar hemorrhage or something that necessitates a bronchoscopy, or more of a subacute cause of respiratory failure that I don't think is going to rapidly evolve. Outside of those, I may consider a brief trial of high flow or non-invasive, but brief trial as in I follow up on those patients at 1 hour and 4 hours, look at their vitals, look at their PF ratio. If we have expired tidal volume, look at their tidal volume. So I don't really have a definitive approach yet. I think it's evolving as our understanding of the subtypes of respiratory failure in this cohort also evolve. But I would love to hear other people's thoughts on that.
Thank you. We have a question for Victoria here from Dr. Monteiro, who asks, with regards to CAR T, what would you define as high toxicity? What would be the criteria for ICU admission?
Thank you very much. I think that's a very good question. And you will see that this is changing. So I can put in the chat that very nice paper from the American Society of Blood and Bone Marrow Transplant that gave the consensus grading. So what they are saying is that grade 3 and above, both for CRS and for ICANS, these patients need to be in critical care. In our institution, we have a very robust outreach team who is very involved in the management of these patients. So if a patient reaches grade 2, then we as ICU via outreach, we know about them. I think I really hope that in my talk, I tried to just highlight how difficult it is to be robust about the grading and say that you come to ITU if you're grade 3 and above, because sometimes you can be a very comorbid patient that received CAR T cells and you're grade 2 and your trajectory is thus that you need to come sooner rather than later. But what I will tell you is that when your center starts looking after CAR T patients, there is an educational curve that needs to happen. These patients are not like your regular septic patients. They look very well, especially from the neurotoxicity point of view, especially if you do their GCS will always be 14 or 15. So that's why they have their dedicated I-score. What I'm trying to say is, yes, use the grading, grade 3 and above, come to ICU, but also the more experience you get, the more you'll understand that, you shouldn't be too rigid.
But the grading system you presented was really not very convincing. Can't you rely on a clinical assessment as for other patients that you have or have not to admit to the ICU?
Again, a very good question. I would probably say, let's get a patient that shows neurotoxicity. So these patients are going to be very difficult to admit to ITU because, as I said, they look too well. So the only thing you will see is, if you remember, one of the 5 things that they have to do for the I-score is write their name. So what all of these patients do, they choose one sentence and they write this sentence twice a day, every day, through the 2 weeks of observations of CAR T. And I could show you, I have some lovely handwritings as they progress through ICANS and they become more and more neurotoxic, how their handwriting becomes a scribble. Their GCS is fine. There's no hard evidence why they should come to ITU, but yet they should come to ITU for now. So yes, clinical examination, but always knowing the specifics about this treatment.
Okay. Flavio, may I be provocative with you? I would say that in the field of blood transfusions, there are virtually no prospective randomized controlled trials, because the trials we have seen were based on 2 hemoglobin levels taken as a threshold for blood transfusions. But we all agree that we should not decide upon a transfusion only on the basis of a hemoglobin level. A hemoglobin level of 8 may be very different in a young individual being recently traumatized and in an elderly patient with a history of coronary artery disease. So should we try to have a prospective randomized controlled trial on blood transfusions that could be well constructed? And if so, how?
That is a good question, Jean-Louis. To decide if we are going to transfuse, we have to consider also the physiologic parameters, lactate, SVO2, delta PCO2, among others. So we might do a study consider hemoglobin levels and the physiologic parameters all together.
Yeah, but people could say then we should have a good prospective randomized control trial on this. Charles, what do you think?
We have questions without answers.
Sure.
We could try. We need more studies. We have more definitions.
We always need more studies. I agree.
I think such a study would be more than interesting, but it could be very difficult to build. But anyway, it's a very good idea.
Victoria, with your we have a question here for you. So priority to those who send the questions from outside our screen here. Don't you think that considering tocilizumab in CRS is risky, considering that 40% are associated with sepsis? Shouldn't we just use corticosteroids in physiological dose, 200 milligram per 24 hours of hydrocortisone? COVID highlighted the high risk of severe infections after tocilizumab administration.
So again, a very, very good question. I can tell you that the data we have, of course, comes from the US. This is still early stages. I am not sure that the infection rate I quoted is due to tocilizumab. These are not patients that were well. These are patients that have been through conditioning many times. They've been to at least 2 lines of treatment. They had chemotherapy right before, almost all of them, bridging chemotherapy right before receiving the cells. They are unwell patients. So I'll be very cautious in subscribing the sepsis that we see in these patients to tocilizumab. I'm fully aware with what the colleague says about COVID. I am not sure if you've seen CRS, the magnitude of CRS. I am not sure you can harvest it with your 50 QDS sepsis dose of steroids.
Very good. Our time is up. We are right on time. So I would like to thank you very, very much for having been with us for these interesting discussions. And I wish you a very nice evening. Take care. Bye-bye.